Thank you very much, Dr. Iskandar. As I was telling both Dr. Iskandar and Professor Sohn just now, it's very daunting standing up here debating against someone as eloquent and as established as Professor Iskandar Aswa on a motion that is on the surface at least as unpopular as this. But I will try my best, and I hope you will take everything I say in the best of faith.
Slides?
Of course, I don't have my
Please?
slides.
Okay.
Okay, so PrEP should not be made available without a prescription in the Asia-Pacific region. Now, Professor Annette Stone asked me just now if I was new to debating. I'm new to debating on the APACC stage, but I am an invertebrate university debater, and therefore, I must start off by saying that you cannot debate without having a few key definitions. PrEP is HIV pre-exposure prophylaxis, all licensed and approved formulations. We cannot take PrEP just as oral PrEP without taking into account the fact that intramuscular long-acting PrEP is increasingly being available, and I urge you to think about the implications of making long-acting PrEP available without a prescription. Available means it must be available and accessible to all who want it and all who want it now. It is not in the spirit of the debate to have any limits or restrictions to this access. Prescription is an instruction by any authorized medical practitioner. It does not mean a physician. There are many models in the region, in Singapore definitely, and I'm sure in other countries in the region, where prescriptions can be provided by people who do not have a medical degree, but a nursing degree, a pharmacist degree, such as through collaborative prescribing models which are available in Singapore, and other parts in the region, I'm sure. And of course, the Asia-Pacific region is where we are today. I believe that when we are approaching the question of whether or not PrEP should be available without prescription, we need to ask ourselves 4 key questions. Number 1, is it safe? Number 2, is it useful to have such a model for PrEP dispensing and availability? Number 3, does it make PrEP reach those that it most needs to reach? And number 4, is it realistic for us to have PrEP without a prescription everywhere in the Asia-Pacific region? And I believe through what I'm going to tell you through the next 10 minutes or so, that all of these questions will fall, the answers to all of these questions will fall in my favor. Number 1, client or patient selection often still requires a clinician's input. Now, what are the medications that are available, that you can buy over the counter or available without a prescription? If we look at the US FDA recommendations or guidelines for when a medication can be sold over the counter, it must be safe and effective for use by a consumer without supervision by a licensed healthcare professional, which means that it can be used appropriately by consumers for self-diagnosed conditions, has a low potential for misuse and abuse, and does not need a health practitioner for safe and effective use. The Singapore Health Sciences Authority has a fairly similar definition, and as this is where I practice, I've highlighted there that it can be used by the public for minor ailments without medical supervision, and it does include some sort of traditional and homeopathic medications as well. Does PrEP fall under these parameters? Now, Professor Iskandar did an excellent job, and I fully agree with him that PrEP care nowadays is highly protocolized. It's not rocket science most of the time. Certain aspects of client and patient selection may not be best performed by lay providers. And I believe that as long as there is even a modicum of a risk that someone accesses PrEP where he or she or they may not best benefit from it, or even worse, may come to harm, then we should not entertain that risk. That risk is far too great to take, not only because it impacts the health of that individual, but also because it could lead to an erosion of trust in something that is as critical as PrEP. PrEP will only work if it reaches as many people as possible, and as Professor Iskandar showed, there is always going to be pushback. And that pushback is only going to be made greater if there's any possibility of risk. And what does this risk mean? What if someone was actually HIV positive at the time that they were starting PrEP? What if someone did not have the correct hepatitis B serologies done because somehow they slipped through the cracks of a protocolized layperson-developed guideline or algorithm? What if someone did not have renal impairment at the time that they were starting PrEP, but had medical problems that put them at risk, such that when they did start PrEP, something was to happen. Now, I believe in this situation, a clinician or someone who has a little bit more experience and for which a lay training program would not be able to give them the know-how to do so, would be able to catch someone who fell into this category. I don't have to remind you that hepatitis B is a major problem in our part of the world, and the implications for undiagnosed hepatitis B for someone who is then starting PrEP, especially with the tenofovir-containing regimens, cannot be understated, and this is where I feel a clinician's input would be highly useful. I'm going to shift a little bit and ask you, does requiring a prescription mean that you can only see a doctor to provide it? And that's what Professor Iskandar did try to state, right? That it's over-medicalized, it's very difficult for us to get an appointment to see a doctor, and I know, right? We work office hours, our patients, our clients often want to come outside of office hours. They don't want to come to a clinic, they don't want to come to the National Center for Infectious Diseases, they don't want to go to a HIV clinic. I ask you, is the solution to this problem removing the need for a prescription? I say it is not. I say the solution to that problem is to change our systems, is to make clinic hours more flexible, is to make doctors, nurses, and pharmacists who can give you that prescription more accessible to the community. You can't just remove the need for a prescription because the prescription is inconvenient. You have to get to the root of the problem, right? And I think there are numerous examples of demedicalized, right-sided PrEP provision services that still depend on the prescription, even if it is remotely accessible or remotely available. Just because a doctor or a prescriber is off-site does not mean they cannot provide you with a prescription and cannot do the necessary monitoring that is required. PrEP services are on a continuum and on a cascade. Services that are provided along the PrEP provision cascade are provided by people who are experts and best providing, who are best suited to provide these services, and I believe there is still a role for the prescriber in this cascade and in this pipeline. I scoured the internet to look for different PrEP provision models. There is EPIC New South Wales in Australia, which is nurse-led, it is highly successful, it's published, and it shows a high rate of uptake and a high rate of acceptability amongst key populations who access PrEP. It's still provided with a prescription. One Step PrEP in Seattle, pharmacy-centered. People don't have to go to a clinic, but it's still a collaborative prescribing service with a HIV physician who provides a prescription. PrEP Tech in San Francisco of the USA. Telehealth, don't have to go to clinic. You still see a doctor, PrEP is provided with a prescription. Princess PrEP in Bangkok, and I'm standing here very nervous because I can see Dr. Nitaya there. Key population-led. It's provided without a prescription, but closely followed remotely by physicians or doctors. Now, I'm going to move on to a slightly more boring argument, right? But nonetheless very important. When we set up something new, when we have something that's innovative, that's fresh. I mean, PrEP is no longer fresh, I know, but relatively speaking, compared to condoms, compared to other modes of prevention, how do we decide if it's useful or not? We have to have results. We have to have monitoring, we need to have evaluation, we need to set benchmarks, and we need to know whether things have met those benchmarks or not. The World Health Organization has issued guidance on PrEP delivery, and it recommends close monitoring and evaluation at clinic level, at healthcare system level, at national level, and at global levels. And I put it to you that when you have a prescription, when you have a paper trail for how many tablets are going to how many people at how many settings, it allows you so much more ease to monitor and evaluate whether it's reaching people who need it or not. And I believe that when you have to answer questions to UNAIDS that say, what are patterns of PrEP use? How are referrals and linkages working? How many tablets are reaching how many people at risk? Having that paper trail, having an Excel chart with numbers on rows and columns allows you to do that monitoring and evaluation so much more easily. PrEP in the wild simply doesn't work in this respect. And here's the part of the argument where I want to have my cake and eat it as well. Not now does not mean not always, right? I put it to you that PrEP in the region is still developing, it's still nascent, compared to PrEP in the coastal cities of the United States, compared to PrEP in the major urban cities in Australia, compared to PrEP in Western Europe and the United Kingdom, there is still room to grow and develop. Not all of us are as successful as Bangkok, not all of us are as successful as those cities that I talked about in terms of PrEP and in terms of key population-led services. I fully believe, and I fully agree with Professor Iskandar, that these services, key population-led health services, is the way to go. I put it to you that the time is not yet now. We are in the process of building capacity. Conferences like this reach key populations to inspire them, to teach us, not just, not them, but us, about how we can do things better. But if we were to have this kind of massive, rapid change at this time when we are not yet ready, the possibility for things going horribly awry are definitely there. And I think that's not a risk we should take. I show this slide, thank you. I show this slide because I snapped it this morning during Professor Prapan's talk. Everyone is using the same slide. Everyone is bringing up the same statistic. Nearly 80% of all PrEP for key populations in Thailand is provided by key population-led services. But I show you that the 80% didn't start right away. It took time to get there. It is on a curve. And I put it to you that not all of the Asia-Pacific is at the extreme right side of the curve yet. Most of us are on the extreme left. So it will take time. And the motion does not say that we should not have a prescription 10 years later. The motion implies we should not have a prescription now. So, this is my last slide and my last argument. That what is the problem and what is the solution? Professor Iskandar brought up many things. People are not accessing PrEP because of stigma. People are not accessing PrEP because of accessibility. I'm not going to show this slide, but I'm going to tell you that in this JIS paper, authored by Dr. Nitaya and others, it showed that key reasons why PrEP was not reaching people because low levels of PrEP awareness, competing health priorities, stigma, cost, and stigma around PrEP use. This was published in 2016. Professor Iskandar was the co-author on this paper, published in 2023. What were the problems that were raised here? Low levels of PrEP awareness, competing health priorities, health-related stigma, high levels of cost and stigma. Nothing has changed. And not one of these problems can be solved by removing the need for a prescription. I rest my case.